Hello and welcome to episode 43 of ERRX. Back in episode 17, Dr. Nick Tsipis and his team from the Emergency Medical Minute had me on their podcast. We talked about a few high-yield ER topics including sedation, antibiotics, and anticoagulation reversal. If you haven't heard it yet, I highly recommend you check it out on the ERRX podcast or on the Emergency Medical Minute podcast. This week, Dr. Nick Tsipis takes over the ERRX podcast to talk about a topic that I'm a big fan of, but one that is outside of the scope of a pharmacist, and that topic is intubation. From a pharmacy perspective, intubation just looks so gratifying, and although we don't get to do this procedure, which is probably a good thing, I still think that pharmacists, nurses, ERTs, you name it, should be very well versed in the procedure. Taking it one step further, our listeners should be aware of awake intubation. Since we rarely, if ever, do awake intubations at my site, I wanted to hear Dr. Nick Tsipis' take on it. So without further ado, here is Dr. Nick Tsipis discussing awake intubation.
Hello everyone, this is Nick Tsipis from the Emergency Medical Minute. As many of you may remember, Adis Carrick was kind enough to come on our podcast several months ago. We are so thankful to have had his perspective and experience as a clinical pharmacist who's spent time in the ICU and the ER. We talked about a number of topics during that podcast. We talked about antibiotics. We talked about anticoagulation reversal, post-intubation sedation. It was wonderful having him on, and he asked if we wouldn't mind coming on in return to talk about some other kind of clinical topics. And so here I am to give kind of a brief overview and review of awake intubation. So first and foremost, link to the show notes. We will have to Life in the Fast Lane, to MCRIT with Scott Weingart and others. There's a number of great resources online to help you prepare and plan for the moment in which you need to be able to awake intubate a patient. And, first and foremost, obviously the most important thing is appropriate patient selection. So these are folks who you think have an anatomic or physiologic need for awake intubation, where you don't want to subject them to the usual doses of RSI or even delayed sequence intubation that we use. You don't want to lose their vascular tone, and just folks who you need a little bit more of a controlled environment, who you want to take kind of an extra layer of safety to ensure that the intubation goes smoothly. The important thing to note is you do need a little bit of time to get set up. As you'll see in the show notes, pre-treating them with glycopyrrolate or less commonly atropine for secretion management usually is best done 10 to 15 minutes ahead of time. And so you start by doing that. You follow that up with suction and using 4x4 gauze to help clear secretions and saliva from the airway. And then you begin the actual anesthetic process, in which you use a nebulized solution of 4% lidocaine, and you nebulize that at 5 liters per minute, which then helps to kind of anesthetize the posterior oropharynx. Usually very well tolerated, actually, and I've found kind of clinical use of this in a number of ways, whether it's post-tonsillectomy bleeding control, posterior epistaxis symptomatic control. There's a number of different clinical scenarios in which nebulized lidocaine is helpful. So once you allow that to complete, you continue to control the patient's saliva and secretions by suction and using your 4x4 gauze. And then you can add on additional layers of anesthetic by having the patient gargle viscous lidocaine. Also, if you're fortunate enough to have an atomizer to do that, you can actually extend that anesthetic down closer to the cords. I won't get too much into the details of that. That device is not widely available, but certainly the videos from Scott Weingart linked to and the Life in the Fast Lane review do show how beneficial it can be if you do carry it. So once you've achieved your
anesthetic as best as you can, and the patient, you can test this by using the suction canister, or excuse me, the Yankauer or suction device into the posterior oropharynx and seeing if you elicit a gag reflex. If the patient appears appropriately anesthetized, you can start the actual procedure. So, just like your normal intubations, the pre-oxygenation and positioning are key, making sure that you line either ear to sternal notch, or at least the cords to kind of sternal notch with head and neck positioning, and then I think this is one that's readily amenable to video laryngoscopy. You can use direct, but I think it's generally better tolerated, particularly with hyperangulated blades, to use video. And so you're just gently micro movements, looking with your video laryngoscope until you visualize the chords. I do recommend that as you're doing this, you have your sedation agent of choice on hand. Again, we're trying to avoid high doses, but I think that most of these patients, in my experience, need at least twilight, meaning pain dose ketamine or low dose propofol, 10, 20 milligram aliquots every couple of minutes, just more for anxiolytic properties, for a little bit of pain control, early or light, mild sedation, just to make sure that this procedure is as comfortable as possible, and you minimize kind of their agitation and resistance to your ultimate intubation. So pre-treating in the ways that we discussed, having your sedation on hand, prepping the appropriate patient, and then using a bougie. There's a number of resources that we'll link to that are pretty clear that using a bougie and therefore having a placeholder is preferable. The last thing you want to do is to go through all this effort, but the patient is still awake, and you're attempting to place a full endotracheal tube, which is quite irritating to the cords and to the trachea. The patient's gagging and uncomfortable, and the procedure is not successful, and then you have no placeholder. So I think the bougie tends to be a little bit better tolerated. Weingart specifically discusses additional doses and higher doses, 50 milligrams of propofol, or he talks about ketofol, when you are passing the bougie, because that part in of itself tends to be the most uncomfortable part of the entire procedure, and so if they do start to cough, then you sedate them a little bit heavier at that time, and also it's obviously a little safer because you clearly have a placeholder in the airway. So then you finish out with completing the airway as best as you can, and you move on to your post-intubation sedation and post-intubation analgesia and post-intubation management kind of checklists. But I think it's an important procedure to have ready to use for a patient that we don't feel comfortable fully sedating and paralyzing in advance of having a definitive airway in place. And I think that we can think of a number of clinical scenarios in which that would be helpful. It's not a procedure that we do often, but it is a procedure that if and when we do it, we should be very good at it. And I think that, it requires kind of a thoughtful prep approach, as well as anticipatory approach of needing more sedation or needing to progress to full RSI, depending on how the procedure goes. So I hope this has been a helpful review of awake intubation. We are so thankful to have met and collaborated with Adis Carrick. Hopefully we can continue to do this more, because we cherish his podcast and value his time on ours as well. And please feel free to reach out to either of our podcasts with any feedback, experience, questions, concerns, and I hope that you all are well and staying safe. Again, this is Nick Tsipis with the Emergency Medical Minute. Thank you.
Perfect. Thank you all so much for your time, and thanks again to the Emergency Medical Minute crew. Remember to check out our website, errxpodcast.com, where you can find all of our past episodes and look through my Read by QXMD collection for my references.